Hi, Dr. Brian Koffman, doctor turned patient at ASH 2013. You want to introduce yourself, Dr. Sharman?
Sure. My name is Jeff Sharman. I'm a hematologist oncologist, but I direct the hematology research program for U.S. Oncology.
So we haven't talked. I've talked with a number of doctors, and we've hardly talked about any chemotherapy. But there was a very important phase 3 trial of FCR versus BR here, which is something that a number of patients are still looking at and facing. So you want to kind of walk us through that trial?
Yeah, this actually going to be presented here in just an hour or so, so we're looking forward to it. Okay, let's start with the basics. This is a randomized phase 3 study. Okay, and in the randomized phase 3 study, you say to your doc, okay, I'm willing to go into this study, and essentially it's a flip of a coin as to which of these
computer switch
yes,
is
it's
the coin. Yeah,
right.
You don't get a flip.
We're not doing coins these days,
yeah.
but yeah, in essence, it's a 50-50 chance. And in this study, patients either receive bendamustine rituximab or FCR.
So that's the BR versus FCR.
Yeah,
and the FCR is fludarabine, cyclophosphamide, and rituximab.
Absolutely. So FCR, in many people's opinion, is the established standard of care for what we consider fit patients with CLL.
The go-go patients.
Yes, there's go-go, slow-go, and no-go, right? So the go-go patients are ones who have good medical fitness, don't have a whole lot of other medical comorbidities. Okay.
And until recently was the only thing ever shown to prolong overall survival.
So FC versus FCR showed that FCR improved survival, and that was really the first randomized phase 3 study to report an overall survival benefit for for patients with CLL. Now, what happened was bendamustine rituximab sort of came out of nowhere. It's a fantastic story of drug development out of East Germany that then came to West Germany and then to the NIH and then at large. Drug got approved, drug works great, and I think what has happened is, again, if you look at patterns of care data, bendamustine rituximab and FCR have been sort of dueling for supremacy, even though there's never been a study to compare the two head-to-head until now. And the reason this is important is the following. Right now, aside from obinutuzumab, which we've talked about in prior sessions, none of the new experimental drugs are approved in the frontline setting. So for a patient who needs therapy today, who's fit for chemotherapy, these are pretty much the choices to be made. And we didn't have the data to tell us until recently what's the right thing to do. So what does the data show? Data shows that on aggregate, before we get there, how did the randomization work? Randomization is supposed to take into account all the variables that patients bring into clinical studies.
Both groups are equal. You bring apples to apples.
Now, most of the time that works. Sometimes it doesn't. It has nothing to do with the clinical trial drugs. In this particular study, there was an unfair disadvantage to bendamustine rituximab because it had more patients with 11q minus, one of the adverse prognostic features. So anything you want to try to take from the data, you kind of have to keep that in the back of your mind that the 11q minus hasn't been separated out.
But you would think that bendamustine would work because it's an alkylating agent, and chlorambucil are not cyclophosphamide is so important with.
And it may, but it's just saying that in one group you had slightly more risky patients than in the others. So
17p was easy.
17p was equal. Mutated, unmutated was equal.
Age.
Everything else worked in the randomization, but the 11q stick out. So. Patients were treated, and I think you can talk about kind of two main things, safety and efficacy, right? So in terms of efficacy, it looked like on aggregate, FCR was a little bit better than bendamustine rituximab in terms of depth of response, duration of response. If you split that by age groups, those patients less than 65 derived more benefit than those patients older than 65. So the older patients, it was much more of a wash in terms of how people did, in terms of depth of response and duration of response. The minimal residual disease favored FCR over bendamustine rituximab, but also more so in the younger population of patients. Above 65, it was closer to equal. And I think that this has something to do with fitness. How fit are these patients? Above age 65, you do start seeing things that are subtle, mild differences in kidney function, which gets rid of the fludarabine and so on and so forth.
And we know as physicians that people can have normal kidney lab tests, but a normal creatinine, which is a measure of a breakdown product, is in a 65-year-old is a lot different than that same level in a 25-year-old. They have different meanings.
Exactly. Safety, though, is the other side of the same coin, and more patients who received FCR had toxicities from therapy, and I believe the number, I haven't looked at this recently and will be presented shortly, but something along the order of 80% of patients on FCR had grade 3 or 4 hematologic toxicity, which is a way of saying this really wiped out their blood counts for a while, and that either led to a hospitalization or some infectious complication and so forth. Now, if you look, grade 3, 4 toxicity, what does that mean? Well, if you look at the number of patients who died during therapy, it's about 4% on FCR. And I think that that's an underappreciated factor that does argue that it has perhaps a riskier.
And how does that compare to the BR?
So I believe the BR, and let me double check this, I hope I get this right, I believe that was about 2%. So there's a mild change. How much of that, is that I suppose that's sort of the tip of the iceberg with a bigger iceberg underneath in terms of the associated side effects. So I think that what happens, and when I think about this, if I were a patient, I think for a physician who's experienced in giving FCR, I think that FCR is a very good therapy. I think for a physician who's inexperienced giving FCR, it can be a dangerous therapy. And CLL is the sort of disease where sometimes sometimes a physician may only treat 1 or 2 or 3 a year and not understand the subtleties and what to be watching out for, maybe when to back off on therapy, and so on and so forth. So I think that FCR should probably be administered by somebody familiar with FCR, and that could very well be a community practice physician, absolutely, as long as they've done it a number of times and are comfortable with it. Bendamustine Rituxan, I think, is easier to use. You don't see quite the degree of side effects. So,
and that may be why we're seeing so much of it, even though the data hasn't been there.
Yes.
Because the community oncologist feels more comfortable with it.
Yes, I think that's exactly it. And I can tell you, I've sat in rooms where there's community oncologists and academic oncologists arguing about how CLL should be treated, and there's some pointed barbs that are shared at times.
So I have 2 responses to this. The first is that it's one of the reasons that I argue that, based on the Mayo Clinic, but just based on my own experience, that the ideal makeup for care of this is you need a CLL specialist who's got a waiting room full of CLL patients, not somebody who sees 1 or 2 cases a year new with CLL, because they need to know what they're doing with that. And the second part of that is that my concern with the FCR is that a lot of people don't get through the 6 courses, and though there's some recent data that suggests if you get to MRD negative, it doesn't really matter if it's after 3 or 4, but a lot of people don't get there because of the side effects and toxicity. So
I think you're absolutely right, and it's one of the things I'm going to try to leverage some of my resources to utilize is how many patients receive 4 or more cycles of FCR, and if they receive less than that, is that because somebody just stopped early, or was there side effects that led to that termination? I think that treatment intensity is something we'll just sort of say regimen this, regimen that, but we don't always factor into that the treatment intensity that's associated with it. And I think that there's some unmeasured benefit to be captured from looking at that.
All right, so in the last minute here, can you kind of give us a summary of anything you want to share with us?
So I think with regards to FCR versus bendamustine Rituxan, I probably would tend to favor it in the younger, more fit patients, and bendamustine Rituxan, even though this was ideally the same patients side by side, I'm more willing to do bendamustine Rituxan in those patients older than 65. And this is a gray zone, right?
Right.
You could have a great 67-year-old or a bad 62-year-old. But I
Tate
kind of
Schoenfeld
use
did
that.
a nice paper on
Yeah.
that,
Yeah.
about what age means, and we've had some
Right.
discussion on that.
Right. So that's my take home from this that I'm taking back to my practice.
All right, well, thanks as always. It's so exciting to have some stuff that, like I think before we talked, that kind of moves the needle
Yeah.
on this and changes things.
My
Great to
pleasure.
see you, look forward to seeing you again.
Thanks so much. Take
Thanks.
care. Good.